Okay, let me put my sunscreen on before we talk about skin cancers. So we have malignant melanoma, which is a cancer originating from melanocytes. Okay, melanocytes are cells which produce melanin, which protects us from the UV radiation. So one of the risk factors of getting malignant melanoma is sun exposure, UV radiation exposure. Okay, and then fair-skinned individuals. Okay, and then familial, of course, and dysplastic navy. Okay, so the types of malignant melanoma that we have: number one, we have superficial. As you can see here, we have superficial, the black part, superficial spreading melanoma. Okay, it has irregular edges. As you can see, it has irregular edges, and it's commonly seen in whites. Okay, in whites, and then it spreads horizontally in the epidermis, okay, and then it's commonly found in the sun exposed areas, as you've just said, okay. So nodular type, on the other hand, it tends to spread vertically, like this vertical invasion, okay, and then there's also ulceration, okay, and then the lentigo maligna melanoma, okay. So lentigo maligna melanoma, assuming it's this one, it will affect mainly the face, the elderly, okay, and the epidermis invasion, of course, this epidermis invasion. So then acrolentiginous melanoma, let's assume this is an acrolentiginous melanoma. This is a black dye, so it's common in the blacks, and then also see its hands and feet, it's common in the palms and feet soles, okay. And then, so how do we diagnose malignant melanoma? Clinical, okay, and then biopsy. And what types of biopsy do we have? So we have excisional biopsy, whereby we excise the margins of that tumor, okay. And then we have incisional biopsy. Incisional biopsy, we take a portion, like a wedge resection here, of the tumor together with some normal part of the skin, okay. And then we have punch biopsy. Punch biopsy, we take patches, okay, like around 4 patches, okay. And then shave biopsy. Shave biopsy, we come and shave, slices. We cut layers, okay. And then classification of malignant melanoma. Remember Breslow's 3 important numbers: 0.75 millimeters, 1.5 millimeters, and 4 millimeters, okay. So if it is less than or equal to 0.75 millimeters, that is Breslow's stage 1, class 1, okay. If it is between that 0.75 to 1.5 millimeters, so our 1.5 millimeters, the upper margin, that is stage 2. Stage 3, it is 1.5 to 4 millimeters, okay. And then stage 4 is more than 4 millimeters, okay. And then there's class staging, stage 1 to 5. So assuming this is our malignant melanoma, if it is confined within the epidermis only, that is class stage 1, okay. If it affects up to the papillary dermis, this is the papillary dermis, but not up to the interface, that is stage 2. If it affects up to the interface, but not to the reticular, that is stage 3. If it affects up to the papillary dermis, up to the papillary dermis, that is stage 4. If it affects all the way up to the cutaneous tissue, okay, assuming it has affected all the layers, and then up to the subcutaneous tissue, that is stage 5, okay. And then we have pathological staging, we use TNM and lateral digitedness, and then so clinical stage 1, it is confined in the epidermis. Stage 2, there's regional lymph nodes involvement. Stage 3, there's metastasis, okay. And then what are the treatment of malignant melanoma? So our options are surgery, of course, that is the mainstay. So we do excision with wide margin resection. So assuming this is our tumor here, so if it is in situ, we're going to do 0.5 centimeters margin excision. If it is less than 1 millimeters, we're going to do 1 to 2 centimeters margin excision, 1 centimeter margin excision. And then if it is 1 to 2 millimeters, we'll do 1 to 2 centimeters margin excision. And then if it is 2 to 4, 2 centimeters margin excision. If it is more than 4 centimeters, it will be more than 2 centimeters margin incision. And then remember sentinel lymph node, that is the first lymph node you inject dye. And then if it is affected, you do therapeutic lymphadenectomy, okay. So we go to basal cell and squamous cell carcinomas. What are the risk factors? Of course, sun exposure, fair skin, family history, fistulas, is arsenic, tar, immunosuppression, and irritation. Of course, old age as well. That's why you find a lot of elderly people, they are always wearing a cap. It's a risk factor, okay. So basal cell carcinoma, assuming you take this to be our basal cell carcinoma, it's common in the Caucasians, okay. The Caucasians in the sun exposed areas, there's local invasion. It's most of them are slow growing and asymptomatic. What are the types of basal cell carcinoma? So we have nodular. So as you can see, we have our nodule here. So it would be nodular, which is the commonest type, okay. Commonest. There's ulceration, formation of rodent ulcer, and it's mainly found here. You see this region between the angle of the mouth, the here, it's always found around here. And then the pigmented type, assuming this white part, this is our pigmented type of basal cell carcinoma. So it's mainly found in the black races, okay. It is black in color and because of the melanin deposits, okay. And then in the pigmented races, and then in the superficial type, assuming the red one is the superficial type. So this one is erythematous deform and erythematous scaly plaque, okay. And then morphiform, assuming this is our morphiform type, it has ill-defined margins, as you can see, ill-defined margin, okay. And then there's subclinical extension, okay. So treatment, what are we gonna do to this? We're gonna do curated electrodissection, okay. Curated electrodissection, and of course surgical excision, okay. Then use, of course, targeted therapy and topical imiquimod, okay. And then squamous cell carcinoma, our squamous cell carcinoma here. So what we need to remember about squamous cell carcinoma is that, so we have broadest classification of squamous cell carcinoma. If differentiated to undifferentiated is 3:1, that is stage 1, okay. If they are equal, differentiated to undifferentiated 1:1, that is stage 2. If undifferentiated are more, that is 1:3, that is stage 3. If all of them are undifferentiated, that's anaplastic, that is stage 4. And as for prognosis, spread hematogenously through blood to bone, brain, okay, and lungs, and then it would spread regionally to the lymph nodes, and then there's local invasion, okay, which could be vertical or horizontal, okay. And then of course treatment is gonna be chemotherapy, excision, okay. And then in situ, let me mention this: if you get a squamous cell carcinoma, which is in situ, anywhere in the body, that is Bowen's, okay. And then if you get it on the prepuce, that is erythroplasia of Quayer's.